morning, good afternoon, and good evening to our wonderful chairs, speakers, and audiences all around the world. We are back again with another session of ACNS webinars for you. Today, we have a list of two wonderful speakers and chairs who will be enlightening us with their scintillating lectures in the next few hours. The speaker for the first session of today is our honorable guest from Morocco, Professor Nasia Al-Abadi. Before we begin her introduction, I would like to sincerely congratulate her on behalf of the President, Professor Yoko Kato, and various members of the ACNS on being chosen as the first female president-elect of WFNS in the recently concluded elections. Indeed, these elections were very special, and we have a wonderful result with the first female as well as the first president from Africa. Congratulations. Professor Nasia Al-Abadi is a professor and head of the Department of Neurosurgery at the Sheikh Zayed International University Hospital, Morocco. She is also the chairman of Department of Surgery, Abul Qasis International University of Health Sciences. She is the founder and director of the Stereotactic Brain Surgery University Diploma, Mohammed Vid University Rabat Reference Center for WFNS. She is the president of the Moroccan Society of Neurosurgery and also the past president of the Pan-Arab Association of Neurosurgical Societies and the Mediterranean Association of Neurological Surgeons. She was the treasurer of the Continental Association of African Neurological Societies and chairman of the WFNS WIN committee. We are extremely honored to have her today as a speaker, and she'll be talking about lessons learned from childhood ependymomas. The speaker for the second session of today is our honored guest from Italy, Professor Marco Fontanella. Professor Fontanella is associate professor and chief of neurosurgery at the Neurosurgery Clinic, University of Brescia, Italy. He was the past president of the Society of Italian Neurosurgeons. He is the current assistant treasurer of WFNS and was the chief of web and publication committee of the WFNS. He is a noted researcher with several publications in various peer-reviewed journals, also an invited faculty to various workshops and conferences held worldwide. We are extremely honored to have him today as a speaker, and today he'll be briefing us about his new classification of cerebral cavernomas. The chair for the first session of today is our honored guest from Sao Paulo, Brazil, Professor Nelson Zenon. Professor Zenon is the head of Department of Neurosurgery, Pediatric Neurosurgical Center, Sao Paulo, Brazil. She was the vice president of the Women's Committee of Neurosurgery and currently president of the Pediatric Neurosurgery Committee of the WFNS. She is a scientific committee member and the vice president of the IGSPN and currently the vice president of the Education Committee. She also held the position of the vice president of the Women's Committee on Neurosurgery. She is a noted author who has published several publications in various journals and book chapters. We are extremely honored to have her today to chair the session of Professor Nasia Al-Abadi. The chair for the second session of today is our honorable guest from China, Professor Shubin. Professor Shubin is the consultant neurosurgeon at the Huashan Hospital, Fudan University, Shanghai, China. He is also the vice president of the ACNS, and his literary contributions to neurosurgery sums up in scores of articles in various internationally peer-reviewed journals and book chapters. And he has the largest collection of bypasses for Moema disease in the whole world. He is an invited faculty to various workshops and international conferences conducted worldwide. He is our main mentor for us with regard to ACNS webinars in China. And with him, we have reached the far and wide audiences worldwide. We are extremely thankful to him for accepting our invitation to chair the second session of Professor Marco Fontanella. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome all the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. Dr. Liu Bun Seng from Malaysia is my co-host for today. And with that introduction, I would like to hand over this platform to our first chair, Professor Nelson Zenon.
Thank you very much for this introduction, Raja. It's a great pleasure to be with friends and share the stage with you. First of all, in the name of the Pediatric Neurosurgical Committee, it's a great pleasure, and I'd like to congratulate Nasia Al-Abadi for the first woman president of the World Federation. It's a great honor for us to have the first woman leading this most important neurosurgical society in the world. And also thanks to Professor Yoko Kato, the first woman neurosurgeon from Japan. Professor Yoko Kato is always our leader. And really we learn a lot from her, not only neurosurgery, but also leadership and humility. And be with these leaders around the world is really a learning curve for me since the beginning. And brain tumors and pediatric ependymomas, Professor Al-Abadi will give us and deliver us a very nice conference. Just some words to remind us that this kind of tumors is considered a rare tumor. In children, 2.2 cases per million, but less than 2/3 will survive after 10 years after this paper from the last 2 years. And when we are talking about ependymoma, it's not only one tumor. For this illustration, we see 9 kinds or subsets of ependymoma, and 4 of them are in the pediatric patients. And the message, probably Professor Nadia will tell us, is that the surgical management is the key perception that we need to have with ependymoma. Is behind the multidisciplinary team, the necessity of pathological review to know that we are treating really the pathology we are leading, and is surgery, surgery, and surgery. And just one word, I got the privilege to work with you, Nadia, from these 4 years, like a vice chair of the WIN committee. When I met you for the first time in Buenos Aires, I couldn't imagine what the next step the world will bring us. And I feel really gratitude for your work. And really, I'm feeling blessed to be on stage and to listen you. Welcome, dear. And I invite you to visit our new website. It's pedneurosurg.org, is the website from the Pediatric Neurosurgical Committee. And thanks for the privilege, Nadia. Welcome.
My dear Nelsie, you know that our friendship, and you just give me one of the photo that I lost it. I would like to have it. Please send it to me. The photo when we was together in Brazil and in Argentina. So first of all, I would like to express my thanks to organizer for their really kind invitation and for your elogious word to me, especially for the election of president-elect, and especially my friend Yuko Kato and Binkstu and Raja. He was very nice to give me this very nice and amazing word. Thank you so much for that. And I am pleased to help build on the success of this webinar with my great friend Nelsie and Marco now and others. So please allow me to share with you this today our deepest sadness of the loss of our friend and sister Suad Bakhti. And what happened? Suad Bakhti what happened with this? May shirt in peace, but for me, she's still here with us. She's protecting, and of course, still lose their lives because of this. I don't know what happened with my. But for me, she's still around, blessing us and protecting us. So within the existing consensus for the best management of pediatric and of infraterritorial ependymoma, as well said by my friend Nelsie, surgery is the most important stage where complete removal should be the perfect aim before complementary radiotherapy. And as she judiciously said, the multidisciplinary for this pathology is crucial. And that, however, remains a challenge even for the most well-trained surgeons because of the vicinity of important brainstem and cranial nerve structure involved, and this is particularly difficult in lateral extension toward the CPA angle. We will see some cases. So some word about epidemiological data. Is the third most common brain tumor in children, and its incidence is approximately 10% of all posterior fossa tumor in childhood. Although their tumors seem to be pathologically benign sometimes, most of the patients still lose their lives because of this pathology. Can you imagine that? It's very sad. Approximately 170 new pediatric cases occur each year in the USA. In Africa, including Morocco, there is a paucity of descriptive cancer data, especially on pediatric brain tumor, unfortunately. And this study conducted in Morocco showed that Ependymoma accounted for 7.6% of all childhood brain tumor. So Ependymoma comprise a heterogeneous group of neuroepithelial tumor that affect children and adults. The majority are seen, of course, in children under 7 years old of age. And MRI shows a well circumscribed midline tumor compressing the fourth ventricle, and hydrocephalus is very, very common. A taurine peak on a spectroscopy MRI might rather suggest a medulloblastoma, the most frequent location in the fourth ventricle, strictly intraventricular, and with the extension outside, sometimes through the Magendie, sometimes through the Lischka's foramen. Full spine MRI for the leptomeningeal and spine metastases is often required. We would like to focus on and discuss some aspect of surgical technique for the treatment of ependymoma that we consider important for effective surgical removal and avoidance of complications. As mentioned, obstructive hydrocephalus is frequently seen. There is a high probability that it will be resolved after the tumor resection. In many cases, if the CSF diversion is unavoidable, it seems that an external ventricular drainage can be preferred to the placement of the VP shunt. We always put the frontal ventriculocystostomy as the preferred access, because after removal of the tumor, a third ventriculocystostomy can be done through the same burr hole, if there is, of course, a need. Among children, the approach to management has remained strictly similar over the past 2 decades. Surgical resection of the greatest extent of possible without unacceptable neurological sequelae, followed by postoperative involved field irradiation. It's still the treatment of this kind of tumor. This is one of my case, 2 years old, who presented with the acute raised ACP symptom at the emergency room. As you can see, the severe hydrocephalus, that's why the shunt was inserted first with a significant improvement, and then I operated on her tumor that revealed to be an ependymoma grade 2. We use usually as a technique the teleovular approach. It seemed to be easy to realize without injury to the elegant areas. And the teleovular approach, you see the image at here in the beginning of operation and the end of the operation here. With the end and the operation, there is a small here with this flesh, the small residual tumor on the floor of the fourth ventricle. I will share with you oops, I will share with you one short video. I of course escape all the skin, the bone, and we are in the televelar. You see here, for example, the tonsil here, the right, and the left here. It's a carton, and then we start to remove the tumor. Here is the tonsil, the tonsillar, the alveolar, and here is the vermis, and we are cleaving the bulk and the tumor progressively. Progressively, you see here one residue in the foramen of Loschka. We try to resect it, and we finally succeed to really had a total resection. And we use the endoscope for sometimes, because you know, in the roof of the fourth ventricle, we have no really, with the microscope, we have not enough visualization. This is why I use usually in the end of operation the endoscope to see if there is a small residue. And here you see, of course, here this is a little bit a small residue that we still let it. So this is the, of course, the post-operative MRI showing a small residue here, as I told you, and also in the roof of the fourth ventricle, even if it seems, at least for me, operatively, that I have achieved the gross total resection, and I use also the endoscope in these cases. She had a radiotherapy post-operatively, and she's now till now she's good. This is 1 year after she had a relapse, which obliged us to reoperate again with the 2 centimeter the size of the tumor you see here. And this is you see the pica, you see, of course, the adherence. There is a big huge adherence of the arachnoid and the dura. We open it with the percussionlessly, and then we are in the right cerebral hemisphere, the pica here, and the tumor. You see the pica. The tumor is here. We try to, of course, have the Belkin, the tumor first, and then the cleavage between all the other structures, and we end this operation at last. This is the last residue which is still on the pica, but we succeed to remove it. See here. And then you see, of course, the fourth ventricle and the aqueduct of Sylvius, and here we respect, of course, the right pica. And here you see the median sulcus as usually, and the base the implantation of the tumor was here when the relapse continue. So we just coagulate it and put it on some surgical. Okay. So another type of difficulties in the is when we have a tumor in the CPA angle. Ependymoma is an anatomical variant of ependymoma in which young age at the diagnosis and anatomical inaccessibility are BIK negative prognosis factors. Using the surgical techniques described in previous slide, gross total removal can be achieved in more than 95% and approximately in 4% near total removal with the moderate morbidity. The lateral type tumor showed a significantly lower 5 years cumulative survival rate and mean survival rate compared to the other type, mid-floor type or roof type. It has been described that lateral tumors are the most difficult to remove because of their anatomical extension. And in order to achieve maximum resection, many neurosurgical technological devices can be helped. The precise MRI imaging allows the surgeon to manage a better per-operative strategy. This is sure with all the different sequences and development of microsurgery and the application of neuronavigation and endoscope, as I show you, provide us a safer environment for the resection. Intraoperative monitoring, very important tool, and for the brain burst suppression master is a neurophysiological technique used to localize the cranial motor nuclei in the brainstem when there is of course some residue on the brainstem. So survival of patients who receive the gross total resection range from 66 to 80% compared with 0 to 47% among patients with a subtotal resection. Unfortunately, the gross total resection historically was achieved is in only 42 to 66% of patients due to tumor location and the risk of unacceptable neurovascular injury. This clearly shows that gross total resection should be the aim of the posterior fossa ependymoma, as it has proven to increase the free survival is about 70 to 8%. So the postoperative rate improved the recurrence-free survival of a patient with intracranial ependymoma, and 5-year survival rate with those more than 45 gray or more range from 40 to 87% is a good outcome. So relapsed ependymoma carries an extremely poor prognosis. We know that, with 5 years over survival reported, decreasing the median time of recurrence or progression is widely distributed at 18 to 45 months. And approximately 9 to 10% of patients develop leptomeningeal dissemination, as it has been reported by several studies, as you see here. So the role of chemotherapy in the management of ependymoma has been extensively studied, but Nelsie show us some molecular studies, but we still now it remains controversial and it's not routinely recommended outside the context of a clinical trial. So the improved biologic understanding of pediatric ependymoma has generated significant clinical and translational research needs to refine conventional management strategies and develop novel approaches targeting molecular pathway, I hope. Despite multi-modality therapy, 50% patients with ependymoma will experience a relapse Majority of recurrence are local and the prognosis is poor after relapse, unfortunately. Pattern of failure seem to be more local in about 80% and distant in only 20%. Those local control is the survival key. And many reports of prognostic factor have been published in the literature. In most of them, longer survival is associated with complete removal, and the extent of tumor removal is influenced by the anatomical location of the tumor. Also, many reports had concluded that age under 4 years has the strongest prognostic relevance with a high incidence of lateral recess ependymoma, which turned out to be particularly poor in prognosis. Adjuvant radiotherapy has a clearly improved local control as well. So, in conclusion, evidence-based summary, maximal surgical resection is feasible. We have to do it. Gross total resection with the double survival in children. Post-operative radiotherapy is the standard in this with this tumor. No prospective trial have validated its role. Important what things very important, it's reserve is CSA in patient with disseminate disease. The role of chemotherapy remains to be defined. Future is the target of molecular pathway. And let me finish with this hope, because this is one of my first case of ependymoma. Hajar operated time she was only 7 years, and she is now 27 and mother of young boy. She teaches mathematics. How incredible life can be. I have now become the doctor of the whole family, and I wish the very same to my youngest patient, Rania, operated 1 year ago. Thank you so much for your attention.
Yes, Professor Zainab.
Congratulations, Nadia. Well done. Excellent speech. And we have already 2 questions on the chat for you. How soon should you recommend the MRI postoperatively for ependymomas in children?
How in term of the time? I think the question is
yes.
that in terms of the time, we recommended 3 months after the 3 months after the surgery. Before it's not enough. But sometimes, you know, it's when it's a grade 3, for example, the evolution of the tumor is very fast, and didn't give you time to do the MRI in the third months. You have to do it before, because you need to know the situation before to reoperate. But usually it's 3 months.
If you have the possibility, Nadia, in your work to do the MRI on the first 24 hours or 48 hours, some authors advise us to try to do MRI on the first day or second day to try to differentiate what is residual and what is recidive or regrowing from these tumors. Did you agree with this statement?
Absolutely yes, absolutely yes. If I can, because you know, I'm working in a private hospital and a private university, but it's not easy to have the MRI, especially in the smaller and a child, because they need to have some anesthesia before, and it's not easy. This is why I don't. I recommend it when I can, when it's possible, to do it before 48 hours in the two days after the surgery is the best, of course. But if not, we do it in the 3 months ago.
On the same sense, Nadia, did you recommend, if the surgery is okay, to wake up the patients immediately, or did you recommend to overnight under anesthesia?
No, immediately.
And the next day immediately?
No, immediately. And if there is some problem with the wake up, we had easily a CT scan to happen if there is a hemorrhage or some complications. But usually it's immediately after the surgery we wake them up then.
Okay. You show us a wonderful case, 2 years old, a patient with intracranial hypertension, hydrocephalus, and a huge posterior fossa with VP shunt previously done or put on the emergency room. If you have the possibility to choose, you are in your department, hydrocephalus and posterior fossa tumors, your policy is try to do systematically VP shunt before, or try to do external ventricular drain during the tumor removal, or endoscopic third ventriculostomy before the surgery, before the tumor removal?
Yeah, the case that I show, it was shunted in another department before to send it to us for operating his posterior fossa. But our policy in our department, we usually put a burr hole on frontal, look like a ventriculocysternostomy, but just for the external drainage. If sometimes after the operation of the ependymoma, and we need it's different for medulloblastoma. Medulloblastoma, we know if you achieve the total removal, sometimes the hydrocephalus continue to grow in and I don't know, you know that very well. Some cases in medulloblastoma need shunt even we achieve the total removal, but with the ependymoma is different. So we put a burr hole on frontal, is the same that burr hole that we perform the ventriculocysternostomy, and then if really there is a need to treat the hydrocephalus after removal the tumor, we use the same burr hole for the ventriculocysternostomy. This is our policy in our department.
We moved for the same policy. Some years ago, it was the policy at that time, perform a posterior burr hole to put the AVD in the same position, just to gain some minutes, and don't put AVD and put again the child in the surgical position. But with some misplacement of the catheter, we just move again to frontal horn AVD before surgery. There is other comments there?
Yes, we can invite comments from the crowd. Professor Suresh Nair is with us. Hello,
Thank you.
Professor.
Thank you very much, Nadia. What a wonderful talk. You are a real neurosurgeon. You showed about operative techniques and all. That is what all neurosurgeons should know. But little like that, either you or Nelsie can answer. These days, we know that genetic abnormalities currently used to predict biological behavior. So, old times we used to tell type A, type B, Ependymomas. Type A in the fourth ventricle recess, it can go to the CP angle area, poor prognosis. Type B in the ventricle or the spinal cord, little elderly people, good prognosis. Because Nelsie started rightly showing a slide which she showed 3 locations, 3 subtypes, and in each location. And now we all know that supratentorial ependymoma are characterized by recurrent oncogenic fusions, and infratentorial by their epigenetic signatures. Either we have a balanced genome or imbalanced genome. So my question, Professor Nadia, is have you divided your ependymomas into type A, type B, and assess their follow-up and prognosis? Nadia, please.
Thank you. Thank you for your excellent question. I think in my talk I try to speak about the two form, but I don't give him the name type I or type B, but I talk about the one of the particularity of one type. It's the type who go through the foramen of Loschka to the CPA angle. This is a bad factor of this type of ependymoma. It's absolutely one of the bad factors. And of course, there are biological molecular. The last slide that I show you, she's now 27, and that time we didn't have any histochemical for the anatomopathological. I'm sure that this not girl, this woman today is among the type. It's a type 1 because she was the tumor is on the fourth ventricle, totally in the fourth ventricle, and it's start from the roof of the fourth ventricle, and we realize the gross total tumor. We never had to there are no relapse after that, and I'm sure if it can possible today to have the molecular biology, we can have some special marker for a good prognosis.
Thank you, Professor Nadia.
That
thank you. Okay.
Your question.
Thank you, Nadia.
Yes, my co-host Shubin saying.
Thanks, Raja. Thank you, Professor, for a very nice presentation. I have two questions, Professor. One is regarding a diagnosis. How certain that do we sure that it's an ependymoma and not medulloblastoma? Is imaging sufficient? Because there are some surgeons who also prefer to do a frozen section. As we know that medulloblastoma, we never infiltrate the floor of fourth ventricle, so we should attempt all out to remove all the tumor. My second question, Professor, do you encounter a transformation of a grade 2 to grade 3 post-radiotherapy, as this is a main concern with other tumors such as meningioma? Thank you, Professor.
Thank you. For the first question, today is very important to have the extemporary anapath. It means I have the anatomopathologic exam in peroperatively, because we know very well that medulloblastoma is very different than ependymoma, but macroscopically it can be seems similar sometimes. So if I had in the exam the answer me it's ependymoma, of course I try my best to do the total resection. But we know also with the medulloblastoma, there is some medulloblastoma you don't need to operate in them. We had a long discussion with Suad and many others pediatric surgeons about this. And in Algeria, I remember Nelsi, the Professor Bouyoussef said, no, meningioma, some medulloblastoma, you don't to touch them because we know some of them, if you touch them, there is no difference. So don't lose your time to operate them. But for ependymoma, we need to operate them. And my answer is the exam, anatomopathologic exam peroperatively is the SOMERS, because because sometimes the strategy is very different. So the second question is about type 2, grade 2, grade 3 is Sorry, can you
yes,
can
yes,
you repeat your question?
Yeah,
Because,
means post radiation, we accelerate the transformation from grade 2 to grade 3. Do you experience such incidents, Professor?
oh, not with the ependymoma, the ependymoma of first posterior. No, maybe in the ependymoma, in the sustentorial ependymoma, yes, but not with the in my experience, at least, and I know that in the literature and in my knowledge, I don't know. Nelsie, you have maybe you are more pediatric neurosurgeon than me, and you have maybe some new news about this.
The transformation on grade 2 to grade 3 after radiotherapy is exceptional, but can help. Yes, can have. We have one case start with grade 1 ependymoma, and at the end, after 2 or 3 reoperation and radiotherapy and re-radiotherapy, it was Ependymoloblastoma. It was high grade at the end after some years.
Thank you, Professor.
Thank you. The question, my question is, maybe the tumor are in evolution to grade 2 to grade 3, or our analysis preliminarily have some not 100% perfection to decide that is grade 2 and grade 3. Is a question of analysis or is question of evolution? Because if we saw in the literature, we can have 30%, 40% of non-conformity if you compare the same sample with different neuropathologists. With the molecular biology, maybe we can have more precision, but we know it's not available everywhere, every time. We need to deal with patients sometimes only with the pathological examination, and we need to decide with this. My question to all of you, usually you ask for a revision of your pathological examination, your second opinion, or you trust the first exam and you still treat only with the first examination, pathological examination?
In my experience, I always do, the first one operatively, and there's the second lecture after the operation. So two lectures every time for every tumor. That of course
okay.
For the meningioma, it's very but for this type of tumors, especially in the fossa, we always have 2 lectures, because we have many surprise. Sometimes we operate some patients, and the anatomist told me it's Ependymoma, but the final lecture is the Medulloblastoma. So I had 2-3 cases like this.
Me too.
Right. Thank you very much. May I kindly inquire one more question? How about supratentorial pediatric ependymomas, so that grow in the lateral ventricle? What is your experience with regard to that?
Sorry, it's about
the
lateral...
supratentorial pediatric ependymoma.
Supratentorial ependymoma is really very different. First, it's concerning more adults than pediatric, of course, with our childs. And generally the ependymoma in sustentorial is a low grade tumor, And we know that this surgery is also challenging because you need to of course, remove the total tumor if you want to be, of course, if the patient be or relapse. And it's surgery with the mortality and morbidity. We know that very well. And but it's easy to operate also. If you if in a lateral ventricle, for example, we lateral, for example, I used by 2 decades before. I use, of course, the transfrontal transcortical, but now I use only the interhemispheric transcallosal approach for the tumor. And really, it's different. We cannot compare this type of tumor. The ependymoma of the cis-territorial is very completely different of the ependymoma of the fossa, and the prognosis is better, of course, is better.
Thank you very much.
What do you think,
Professor Nelsie Zenon? What about your experience?
Yes, it is exceptional to have supratentorial ependymoma in children, but the prognosis is worse if the ependymoma is on the posterior fossa. And there is another question on the chat, Professor Nadia. What the difference between ependymoma and subependymoma? Maybe they are the same, or the prognosis difference?
Maybe are the same in term of surgery, but if, of course, the prognosis is very different. You know that very well, because the subependymoma, it's usually is in some disease like Bourneville, like and this tumor maybe can not no evolution for a long time. Is totally different from ependymoma. It's really two different tumors.
And subependymoma usually are supratentorial and long-term survival and better prognosis.
Yes, thank you. Thank you very much. We can move ahead to the second session. Professor Shubin, any comments from your side?
Okay, thank you. Thank you, Professor Abadi and Professor Zeno. Actually, your presentation is very attractive. We have around more than 1,500 audience in the WeChat channel watching this webinar. Congratulations, it's a quite number.
Fantastic.
Thank you very much, Professor Shubin. Is the main support for us. I think we can take a final remarks from Professor Zenon before we move on to Professor Marco Fontanella. Any concluding remarks from your side, Professor Nelsie Zenon?
Thank you very much for the invitation. And Ependymoma is try to combine safety surgery, total removal, and still keeping quality of life. Is very challenging decision, but we need to keep in mind not took all the tumor and give devastating life for the patients, like Professor Nadia Abadi shows to us. Thank you very much, and congratulations for the organizer and excellent presentation, Nadia. Thank you.
Thank you. Thank you very much.
Thank you.
On to the next session, and I would like to invite Professor Shubin to say the introduction part. Professor Shubin.
Thank you.
Thank you. So next speaker is Professor Marco Fontanella. And Professor Fontanella is a very famous neurosurgeon from Italy. And he published a lot of research work and the clinical works for subarachnoid hemorrhage, cavernous malformation, and the AVMs. So now let's give the time to Professor Fontanella. Please.
Thank you. Thank you, Professor Shubin. Again, my congratulations to Professor Alabadi for the election, and I'm very happy to show you something about vascular. Vascular is not dead, and Professor Shubin knows very well this. Anyway, I have to thank Professor Shubin because some years ago we sent to him one of our residents, a young girl, that now she is performing a lot of bypasses here in Italy. I think is the one that is performing more bypasses than the other centers. So now we are dealing with Cavernoma, with a vascular topic. We thought to a new classification for cerebral and cerebellar cavernous malformation. We wrote a paper with other very well-known neurosurgeons such as Ernest Niemi and Daniel Rigamonti and Yoko Kato also. Perhaps you know that the cavernous malformation is quite a common disease. With the NMR, we knew that there is a prevalence of 1 people on 200 inhabitants. But only about the 20% of them will eventually become symptomatic, presenting with headaches, with hemorrhage, focal neurological deficits, or with seizures. So a common disease, more common than aneurysms, for example, much more common than AVMs. And a quite strange disease because we still don't really know the natural history of this disease. We know quite well the disease from, I think, in Italy, 1985, 1987, when we introduced the NMR in the clinical, in the hospitals. So is about 40 years, no more than 30, 40 years that we know quite well the Carbonomas, and so the natural history of this disease is still not clear. Of course, you know that we have familial forms of the disease, and the most of the people are the sporadic form, like this one on the right, and the sporadic form is very oftenly associated with a DVA, with a venous anomaly. So is this the same disease, the familial or the sporadic? Is the familial disease more prone to have an hemorrhage or not? More prone to have epilepsy? We still don't know this. Of course, the disease is in the familial form is a very high penetrance of the disease. We know 3 genes associated with the CCM, but we don't know really the natural history of even in the familial form. Now we move to classification. We don't oftenly use classifications in the CCM. We use very often classification for AVMs, for other diseases, but for CCM we have just 2 classifications. The first one is the Ernest Niemi, we call it Ernest Niemi classification for brain and spinal cord Carbonomas, was published in 2011, so 10 years ago. 3 points for this classification based on the location of the site. If the the carbonoma is in basal ganglia, infratentorial or spinal cord, 2 points, supratentorial 1 point. If comes with neurological deficits, 1 point, and we without neurological deficits 0 points. So the total is a maximum of 3 points, but I don't know if you really know this classification and if you really apply this classification. Usually is not very used. The second classification is much more used, is the Lotum classification for brainstem Cavernoma. It takes in account the size of the Cavernoma in the brainstem, more than 2 centimeters, less than 2 centimeters. And if the Cavernoma cross the axial midpoint, if there is a DVA, as I told you, in the sporadic form, the DVA is very oftenly present. The age of the patient less than 40 years, more than 40 years, and the hemorrhage if acute, and the subacute or chronic. 7 points is the total. I think it is more used, this classification, for the brainstem Cavanomas. And now there are more and more papers that are using these classifications in the literature. For example, this patient is just come out. It is an external validation of the Lotum brainstem grading system in a cohort of nearly 300 patients, and is very well linked with the outcome of the patients, this classification. But as I told you, the long for supratentorial cerebellar CCMs, the natural history is not known, and especially for incidentally discovered CCM in this in Journal of Neurosurgery in 2014, in this paper of Kelly Fleming of the Mayo Clinic paper, a cohort of more than 100 patients were followed for a long time, and the prospective bleed rate was very, very low, less 0.08%, less than 1 out of 1,000 per patient's year. And no new seizures in these patients were detected. So it's quite difficult to say what to do in incidentally discovered cavernous malformation. Perhaps not to operate is better than to operate, but we have something to discriminate this decision, of course. And what about the treatment? There's a meta-analysis of the 2014. Many patients, of course, in the meta-analysis, but the composite outcome, I mean, the bad outcome is very high, very high. So it's more than 5%, 6.6% of bad outcome. And of course, to operate on Carbonomas is not so safe. Sometimes it's not so safe. Very high for this meta-analysis, 2014. And we have some guidelines. These were written by, in the author, there is Daniel Rigamonti. I know that I think you know him. He's a very, very big name in the States. I know him very well because he's from Brescia, from the city where I live, and this is the consensus of the guidelines written on neurosurgery in May 2017. And the recommendation for surgical treatment are not so clear, It's written that the surgical resection is not recommended for asymptomatic CCM, especially if located in eloquent, deep, or brainstem area, nor in case with multiple asymptomatic CCMs, but the class is very low and the level of evidence is still low. And the second point states that the surgical resection may be considered in solitary asymptomatic CCM if easily accessible in non-eloquent area to prevent future hemorrhage, and so on and so on. And class 2B level C, very low level of evidence. So we thought that we need a classification, especially a classification to drive the surgical indication. So we published this paper. This is a call, an international call for a new grading system for cerebral and cerebellar Cavernoma. So cerebral and cerebellar, not brainstem Cavernoma, no spinal cord Cavernoma is written for the not for the familial form, but for the sporadic form, and is a surgical decision-making score. Was published in June in Journal of Neurosurgical Sciences. This is the classification, takes in account many features. First of all, neuroradiology, if the lesion is stable or not. Two things: if the lesion is increasing in volume in two different NMR, or if the lesion has a bleeding. The second factor is the focal neurological deficits. We will see it in particular. And the third one is seizures. The fourth one is the site of the Cavernoma. The fifth is the age of the patient. So we can write a score between -1 to 10, and higher is the score, and higher is the grading, is the indication of surgery. Okay. So we can speak of each item. The first one is neuroradiology. The neuroradiology and the presence of the Cavernoma is performed by NMR, and we put in the score two fundamental aspects: the presence of acute bleeding and the increase in size of the lesion. No classifications take in account the increase in size of the lesion, but we know that if we perform several NMR to a patient, many patients has an increase in size of the lesion, and in the literature, the increase in size of the lesion is connected with the occurrence of neurological symptoms. So we attributed to this element 2 or 3 points to the hematoma. So an hematoma bigger than 1 centimeter, 3 points. An hematoma that intra or extra lesional less than 1 centimeter, 2 points. If the Carbonoma is increasing in size in 2 NMRs, 1 point, and for stable lesion, 0 point. Of course, we can have a case like this where an increase in size of the lesion is also associated with the bleeding of the lesion. And for a case like this, of course, we don't sum the points, but we attribute 3 points in hematoma more than 1 centimeters, and not 3 points plus 1 point, which is the increasing sign. So this case, neuroradiology hematoma 3 points, focal neurological deficit because the patient was symptomatic 2 points, and seizures, no seizures, 0 point. The site of the lesion is deep-seated in the basal ganglia, so -1 point. It was a young male, so 1 point, and the total is fine, and the patient is surgical, needs surgery. What about the neurological symptoms? If we have no symptoms, 0 point, but if we have symptom, 2 points, not 1 point, but 2 points, because the weight, of course, we performed all this grading with a statistician, and he attributed 2 points for the presence of a focal neurological deficit. Seizure is very interesting topic, and it should be considered in cases of indication for surgery or Cavernoma. If we have no seizure, 0 point. If they are controlled by medication, 1 point. And if they are drug resistant, 2 points. You know that Carbonomas is very often is drug resistant or become drug resistant. We used to put the patients under antiepileptic drugs very shortly after the first seizure, and especially in young patients, a cortical Cavernoma is often associated with seizure, and this seizure become drug resistance. 2 points. The last is the site of the Carbonoma. If the Carbonoma is dis-seated in critical area, -1 point. What does mean dis-seated? Means like this. Therefore, basal ganglia, internal capsule, and thalamus. This is deep-seated in an eloquent area, in critical area. So -1 point. If the patients if the Carbonoma is subcortical or deep cerebellar, 0 point. If is in critical area, what does mean critical area? Like Lotum described, critical area is pre-Rolandic, post-Rolandic, calcarine, and Wernicke area and Broca's area. According to the Lotum definition, 1 point and 2 points if the Carbonoma is cortical, not in critical area or superficial cerebellar. The age of the patients, as you saw that the cutoff for age for brainstem Carbonoma is 40 years. We decided to put a cutoff as 50 years for cerebral and cerebellar Carbonomas. More than 50 years, 0 point, and less than 50 years, 1 point. So this is our classifications, and surgery can be considered when the score is 4 or more than 4. Let's see something. We call it the 4-Casco grading. 4-Casco is Fontanella Rigamonti Cavernoma score, and 4 means the 4, which is the minimal score to consider the patient's surgical. And you can write a table like this, where, for example, we can take a cortical Cavernoma, so 2 points without neurological deficits, okay, with uncontrolled seizure, so 4 points surgical, okay. And then, of course, is surgical even if the lesion is stable lesion and the age is more than 50. Is more strong. This is indication in young patients and is more strong in young patients with a increasing lesion in size, and of course the maximum score, which is, I think, is not reachable, because you should have a cortical untractable seizure with neurological deficits, with hematoma. Of course, every one of us should operate a patient like this. So let's try to classify some cases. Of course, no one of us would operate a patient like this. Stable lesion in 2 NMR, no neurological deficits, no seizure, deep-seated in critical area, and more than 50 years, so less than 1 point, minus 1 point, and so is not surgical. Another case, this is an extra lesional bleeding, less than 1 centimeter, 2 points, slight hemiparesis, 2 points, no seizure, subcortical, the patient's age 42, 1 point, so the total is 5, surgery, and we did operate the patients, and he did well. Another case, stable lesion, but no neurological deficits, but drug-resistant seizure, is cortical, not in critical area, 2 points, 54 age, total 4 points, surgery, and indeed we operate on him. This is a stable lesion without neurological deficits, no seizure, subcortical Cavernoma, 40 years old, 1 point. It is not surgical, a case like this. But this is another case. There's a stable lesion, non-neurological deficits, seizure controlled by medication, cortical not in critical area, 35 years, 4 points, so surgery, we operate on him. And this is another case. Lesion was increased in size, 1 point. It did not have neurological deficits, 0 point, but with intractable seizures, medial temporal lobe Cavernoma, so many seizures, intractable. We consider this not in critical area, cortical not in critical area, so 2 points, and 1 point because it was less than 50 years old, so total 6, surgery. We used to perform many cases of this, of medial temporal. We operate through supracerebellar and subtentorial, transtentorial, like Toure shows us. Like here, the tentorial edge is cut, and here is the medial line. You can reach the ambience instance with the right PCA and the Rosenthal vein, and you take off the Cavernoma, and here you have the para-hippocampal gyrus. You see, you can take off the Cavernoma, and the end you can see the posterior inferior margin of the thalamus here. And here this is the pre-op and the post-op. The pre-op and the post-op, you can see here what we pass under the tentorium, through the tentorium. I think that many perform operation like this. This is another case, and I'm sorry, and we consider this not surgical. This is another case with mild right hemiparesis, 2 points, no seizure, deep-seated in critical area, and a young man, and so 5 points is quite difficult cavernoma here, in very near the internal capsule. We used to perform awake surgery. In this case, you see the DTI fibers is just inside the internal capsule, but we know we can reach it and take it off. You see it inside the internal capsule, but we can reach it and take off the cavernoma, and the spinal tract is intact. The man is a truck driver and is completely free of symptoms now. Okay. So we retrospective so our casuistic, our series, we perform in the 10 years about 300 surgeries. And this is a retrospective analysis. When we operate on this patient, we still did not have this classification, but we put our patients on this classification, and we saw the outcome of the patients on the basis of this classification. So for the surgical cases, we perform about 300 cases, and when the score of we operate patients with a score equal or more than 4 in 92 cases, and only in 8% of the cases with a score of less than 4. When the grading was respected, so in these cases, in the 92 cases where the grading was respected, we have an improvement, or the patient was stable in the 98 of cases. And when the score was not respected, we had an improvement, or the patient was stable in only about 60% of cases. So we think that this we were going to analyze this data and to publish our series, and just to show that to perform to classify these patients with this classification allows to have an improvement of or stabilization of symptoms in most of the cases. We follow up for many years, 9 years, nearly 80 patients. 50% of them had a score more than 4, and 85% less than 4. And in all these patients where the grading was respected as an improvement or was stable in the follow-up, and only 8% of the patients where the grade was not respected had an improvement too. So for the identification of what is surgical or not, I think we thought that this grading is very important. I remember you that the grading is not, you cannot apply the grading in the pediatric CCM, familial CCM, of course in the brainstem, Cavernoma, where we have the Lotum grading, and the spinal cord Cavernoma. In all the sporadic Cavernoma, cerebral or cerebellar, you can apply this grading. And we are looking for an external validation now. So a big number of patients. We really don't want to see the results of this validation, but if you have quite a lot of a series of patients with CCM, if you are retrospectively classify this patient with this grading, I think we can publish it, and I think it could be very nice to discuss about this classification, or to improve this classification. We spoke a lot with Yuka and Osniemi about this classification, and during the night, and I think is a good one. We modify something, and I have to thank Daniel Rigamonti, because he is really the man that was thinking with me this classification, and now we are trying to validate it. Thank you very much.
Thank you, Professor Fontanella. And this is a very interesting grading system, and especially the negative one. I think it's quite useful. Yeah.
Well,
so
I think
how about
it's not...
the how about the score less than four, but if there's some history of the hemorrhage, so what kind of do you sometimes treat it with a gamma knife?
Yeah. Well, this is the real point. If we don't operate a Cavernoma, what is we have a very short follow-up, because 5 years, 10 years is not enough to say that it is not surgical. Of course, we perform a lot of surgeries in cases with a grade less than 4, and actually we had a good result. But if you do this cutoff, of course, the patient with a grading more than 4 as an outcome much better than the others, that the patient less than 4. Gamma knife. Well, I don't really believe in gamma knife. I think that you send the patient to gamma knife when you don't really know what to do, and is not fair for the patients. You know that the last results on gamma knife says that that is quite useful in reducing the rate of hemorrhage, but not so much. And we have a few patients sent to gamma knife, and some of them had a bleeding in the follow-up. 2 of them, about less than 100, had a bleeding after gamma knife. So I don't know what to say, really.
So how about the dose of the gamma knife? Because if you use routine dose for tumors like 45 grays, it's kind of this kind of dose couldn't be useful, because sometimes it induces the enlargement of the Carbonoma. But if you use a small dose like 15 gray, actually it can induce proliferation of the endothelia. Sometimes it can reduce the hemorrhage rate.
Well, yes, this is another topic. Yes, I agree that perhaps we still don't know which dose to use for the Carbonoma, but we know very well a lot of patients where the Carbonoma was induced by an irradiation of for another tumor, not for other pathologies, and with a very low rate of irradiation. So if a rate of irradiation, I don't know, of 5 gray can induce Cavernoma, I don't know what to say really. I don't know the future. I would be very prudential to send a patient to Gamma Knife for a Cavernoma.
Okay, thank you.
Thank you very much, Professor Marco Fontanella. It was indeed a very, very interesting classification. We hope to build your series up by external validating it. And I hope in future we have a very good number to validate it externally. Yes, Professor Najia Al-Abadi is still with us. Would you like to give your comments, Professor Al-Abadi? Please unmute your mic, Professor. Please unmute your mic, Professor. We can't hear you, Professor. Please unmute your mic.
No, I just say that I'm very interested by this classification. This is why I report my I just postponed my appointment 1 hour to listen to him. It's really congratulations for Marco, because it's a really nice work, wonderful and tremendous, and I hope that you can of course generalize this this classification. But I have a question for you. When you say the diameter of the Cavernoma is growing between 2 MRI, what the time between the 2 MRI in your assessment?
Well, this is still very not clear, you know, how to follow up a Cavernoma. If the patient has to perform an MRI every year or every 2 years and so on. First of all, we have to clarify what is an increase of size. We standardize the increase of size of more than 3 millimeters in the maximum diameter. Because we saw a lot of all our cases, and this was, I think, just the minimum size to say yes, is increase in size or not. Then when to perform an NMR is very in our cases, some patients did an NMR every year, every 6 months, every 2 months. So you are right, it's a very clever question. It's not so simple to say this is you know, is more the volume is bigger than before. And another thing is the bleeding, because I don't know your experience, but in my experience, sometimes the neuroradiologist send you the patients and says this Cavernoma, the patient is completely free of symptoms, and the neuroradiologist says there was a bleeding. I don't know when, but there was a bleeding because you see an hemosiderin ring in the Carbonoma, near the Cavernoma. So what should we consider a bleeding of the Cavernoma, especially for small bleeding? We consider as bleeding of the Cavernoma a bleeding and the CT scan. And when you can see the blood in the CT scan, of course, if there is a neurological symptom, you can say that that patient bled. So very difficult. Difficult.
The last question. Yeah, last question is about knowing that the brainstem Cavernoma, for example, or the deepest location of the Cavernoma are more risk to bleeding. Do you take in consideration this on your classification?
Yeah, this. Thank you for the question.
Sorry.
Thank you for the question. No, it's very good question. Well, we think that the brainstem Carbonoma is another family. Okay, so we cannot apply this classification for brainstem Carbonoma. But if you see the publications and the article, some publication says that the deep-seated Carbonoma usually bleed more frequently than the cortical Carbonoma, and especially some publication says that cerebellar Carbonoma are different and bleed more frequently. We thought a lot about this. I don't know if this is real. In my mind, I'm not so sure that the brainstem, also the brainstem Carbonoma, bled more frequently than the others. Perhaps are more, the brainstem, everything. If you have one cc of bleeding, of course, the patient is symptomatic. If the Carbonoma is frontal and the bleeding is 1 cc, the patient is completely asymptomatic. So this more is the brainstem Carbonoma are really more prone to bleed, or is our thinking because are more symptomatic, bleeding is more symptomatic? This is a big question, and but I think that the increase in size is a big topic. We thought a lot to put a point for increasing size, but I think we did well, because we know that to increase in size of the Carbonoma is related with a bad prognosis and a worse outcome.
Mm-hmm. Okay, thank you. I know, because the brainstem, I have experience with the brainstem Cavernoma. We had, I think, till now 23 cases, and among them we had more than 18 with the, and the others it's pseudotumors, symptomatic, and really the hemorrhage is very frequent between the brainstem and the others location. It's not because the brainstem is functionally it's really area very eloquent. It's not only that, but really, in my experience, it's more it's more frequently hemorrhage in this in brainstem than other locations. Thank you.
Thank you very much. We have Professor Suresh Nair with us. Professor,
can I ask one question? It was a great talk, Professor Marco, and we enjoyed your forecast of grading. And I understand from your lecture, you don't agree to gamma knife as a modality of treatment for cavernous hemangioma, except in very few locations. What is your take on extracerebral cavernous hemangioma of the cavernous sinus? It is a totally different family of cavernous hemangiomas. Do you send them for gamma knife? Because they respond very well to gamma knife. Marco.
Well, yes. For example, the orbital Carbonoma, I think, are very different. They tend to increase in size, but the bleeding, the acute bleeding, is very rare, and perhaps the natural history of these Carbonomas is very different. And even in my, of course, we now have experience, in my experience, for example, the Carbonomas near the ventricles are more prone to bleed. I saw several bleeding from Carbonomas near the ventricles. So we have really to put together big series of patients to understand something. I think that they are doing this in Mayo Clinic. My friend Giuseppe Lanzino is and Fleming is putting together a lot of Cavernoma, and I think it is more important, even more important, to follow up the cases not operated, that we are following up for years and years. And if we have a very good series of patients, 200, 500 patients follow up for 10 years, I think we can say something.
Thanks, Marco. Thanks for your comment.
My co-host Liubun Singh, any questions from your side?
Yeah, thanks, Raja. Thanks, Professor Marco, for a very nice, comprehensive presentation. Professor, I wish to ask to confirm that your classification, you are dedicated for a single lesion, as you excluded the familiar. I believe that because there are some factors may be related to a single lesion, for example, like epilepsy, for such, whether we need to do an extensive workup to correlate with that lesion. The second thing is, if you plan to treat the patient, what will you do with the DVA? Treat or not to treat? Because DVA was missing from your classification. My last question, Professor, you have 78 patients that 15% of them you think that they should be treated. How about when you look back, those treated and those with a natural history not treated, are they fare better, or they should be called back and to be treated? Thank you, Professor.
Okay, if you see in the literature, about 40% of patients as an association with Cavernoma and DVAs. But in my opinion, the association is much, much higher. I mean that the 80% of patients with a Cavernoma, as with a sporadic Cavernoma, as associated at DVA. You know that some researchers said that is the DVA the pathogenetic factors that is connected with the Cavernoma in the most of the cases. So depends very much on what is the DVA. Is a very, very tiny vein near the Cavernoma? Well, if it is a tiny vein near the Cavernoma, I can close this vein, but usually I like to preserve the DVA. Why? Because in my opinion, of course, there are some recurrence of the Cavernoma, okay, and the novo Cavernoma. But in my series, when I preserve a DVA, I never seen to come back, the Cavernoma come back for the presence of the DVA. So the DVA can be sacrificed if the vein is very tiny, but should be preserved if is a big vein.
Right. Thank you very much. There is a question in the chat.
Last question for Professor Fontanella. So sometimes we can find some edema surrounding the Cavernoma. So I noticed that you didn't include this edema in the grading system.
No,
so,
no, we didn't. Of course, the grading was is a big work, because it took us a lot of years. And first, we thought to include the size. What not to include the size is the same thing to operate a Cavernoma 1 centimeter and 3 centimeters. Couldn't be the same. But if you see your series, is not very different to big Cavernoma and small Cavernoma. And also the other things like edema or the midline shift in cases of hemorrhage. is not so connected with the outcome of the patient. Is more even the hematoma. We decided 1 centimeter, which is small hematoma, 1 centimeter, but we think that more than 1 centimeter and less than 1 centimeter, there is a difference on the basis of our 300 patients. That is not very much, but we saw a difference. So I think I like to see an external validation. I don't want to do myself this. I like to see an external validation, and we can modify the classification. I think we work a lot with Daniel Rigamonti, and Yoko Kato also was in the team to, you know, in the very first time to discuss the classification.
Right. Thank you very much. There has been a question in the chat box which asked about any hormonal influences with regard to bleeding in Cavernoma. Have you ever experienced something?
For the influence on the bleeding of the
Cavernoma.
Well, we are discussing a lot about anticoagulants, anti-aggregation, and perhaps it's not so safe to use anticoagulants and aspirin in Carbonoma, not like in aneurysm that we know we can use this kind of drugs. But there are in the world many associations of patients now of Cavernoma. And this, which is in Italy, we have one IAC, but there is the Angioma Alliance in the States is a really huge association of patients with Cavernoma. Usually they are familial Cavernoma, but many sporadic Cavernoma are even in the association. And they ask us, what can I do, especially for sports, for you know, travel or other things. And we know now that, for example, the sports, soccer, or even sports, American football, they can perform such a sport. There is not, they are not more likely to bleed if they perform a contact sport. So I never met a boxer with a Carbonoma, but perhaps they can do this.
Right. Thank you very much. So we can wind this up. We would like to hear the final remarks from Professor Shubin.
Thank you, Professor Marco Fontanella and Professor Naja. So today, now, we have around 1,600 audience.
Wow,
Thank you for your great achievement.
Thank you very much, Professor Shubin. With that, I'd like to wind this up. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to sincerely thank both the speakers of today, Professor Najia Alabadi and Professor Marco Fontanella, as well as the chairs, Professor Nelsie Zanon and Professor Shubin, for taking out the time and supporting us in our educational ventures. Special thanks to Professor Shubin, who is our main mentor and has supported us in our educational ventures from the very beginning in the form of suggesting world-class speakers as well as broadcasting these webinars in China. A special thanks to my co-host, Dr. Liu Bun Seng from Malaysia, for joining me today. So until we all meet on next Saturday, it is bye-bye from all of us. Thank you, everybody, for joining.